student. And with me is Khalid. He's a second-year medical student, and we're going to give you a brief endocrinology review session, inshallah, for physiology. So starting with the first question. Oh, the outline. So first we'll do pituitary, then thyroid, then adrenals, then pancreas. Okay, the first question. Does anyone want to read or sorry. Okay. So which of the following hormones originates in the anterior pituitary? A, B, C. Wait, let me open the chat. E. Oops. Yeah, I did a mistake, but yeah. Okay. Yes. True. So it is E, thyroid stimulating hormone. Dopamine, growth hormone releasing hormone. Any releasing hormone is from the hypothalamus, oxytocin and testosterone. Oxytocin is from the posterior pituitary and testosterone is from the gonads or the adrenals. Okay, so here is just a quick, brief anatomy about the pituitary gland. So it's located in the sella turcica. And it's made up of an anterior pituitary and a posterior pituitary, and we have the infundibulum here, which connects it to the hypothalamus. So we know that the anterior originates from Rathke's pouch, so it's like of oral ectoderm origin. The posterior pituitary, however, descended. So anterior kind of ascended, and posterior, it descended from the hypothalamus, so it's made up of neurons. And its only axons, the cell bodies, are present in the hypothalamus. And the infundibulum is, as we said, the connection. And for the hormones, the posterior pituitary hormone, we said that the cell bodies are present in the hypothalamus. So they're the ones that are producing the ADH and the oxytocin. And then the ADH and oxytocin are sent to the pituitary hormone for storage. And then from there, they're going to be released based on the stimulus. And ADH is going to increase the water volume, and oxytocin acts on the uterus to cause uterine contractions during birth, and on the mammary glands in the breast to let the milk down. For the anterior pituitary, we have in the hypothalamus, either the gonadotropin releasing hormone, which leads to FSH, LH release in the pituitary, which are going to act on the reproductive system, and then the thyroid releasing hormones, which are going to act on TSH, which are going to release TSH, that are going to act on the thyroid. And then we have here either any dopamine or prolactin releasing hormone, growth hormone releasing hormone from the hypothalamus for growth hormone, and corticotropin from the hypothalamus to ACTH. And we're going to go into more details in a bit. But that's basically just an overview of the pituitary. So the next question is, a 43-year-old male develops a brain tumor that impinges on the supraoptic nucleus in the hypothalamus. As a result, the secretion of which of the following hormones is affected? E, prolactin, B, ADH. Okay, so B or E? So final decision is 1E and 2 Bs. Okay, so it is B. Basically, because the supraoptic nucleus is the one that produces either antidiuretic hormones or oxytocin. So it is going to be the one that's affected because you can't produce ADH anymore. So as you can see here, ADH is produced either by the supraoptic nucleus or the paraventricular nucleus in the hypothalamus. And then this is where the cell bodies are, as we said, and then they're going to be sent to the axons in the posterior pituitary. And ADH is secreted as a pre-pro hormone, and it's secreted with something called neurophysin 2. Its secretion is regulated by osmoreceptors that are present in the hypothalamus. So the osmoreceptors are going to feel the osmolality of the blood serum, And then if the osmolality is high, it's going to say, okay, we have less water, so we need more ADH. So it's going to produce more ADH. However, if the osmolality is low, that means we have enough water, so we don't need ADH. So it will suppress ADH. Another thing is baroreceptors. So baroreceptors, they measure the blood pressure. So if you have high blood pressure, kind of also means that you have a high blood volume sometimes. So it will tell us that we don't need ADH anymore to decrease the blood pressure, basically. And then another thing is angiotensin 2. So angiotensin 2, if you remember from your renal block, it basically is going to increase blood pressure. So if there is increased angiotensin 2, that means that there's low blood pressure in the body, and therefore we need another thing that will also help us increase the blood pressure, like ADH. Because if you increase blood volume by increasing water absorption, you're going to increase blood pressure. The opposite is AMP and BNP, which are natriuretic peptides, either atrial or brain natriuretic peptides, and they're usually released when the body already has excess water. So it's in a hypervolemic state. Therefore, if they're released, that means that we don't need more water to be in the body, so they're going to inhibit ADH. And then ADH basically acts on mainly the collecting ducts, but also the late distal convoluted tubule in the kidney. And it binds to V2 receptors, which are going to stimulate the phosphorylation of aquaporin number 2. This phosphorylation is going to make the aquaporins go into the cell membrane, and then water can go through and be absorbed into the cell. And then from the cell, they're going to leave through aquaporins 3 and 4 to the other side. And therefore, when there's enough water inside, we're going to have decreased ADH, and then the aquaporins are going to go back in any normal. They're going to leave the cell membrane. And that's basically it. The mechanism is through GS, so it's CAMP, C-A-M-P. Okay. Next question. If a woman hears her baby cry, she may experience milk ejection from the nipples even before the baby is placed to the breast. What is the explanation for this? A. Okay. Yes, so it is A. Okay. So what is oxytocin? Just like ADH, it's secreted from the posterior pituitary, but it's produced in the supraoptic nucleus and the paraventricular nucleus in the hypothalamus, just like the ADH. And it's also released as a pre-pro hormone, but this time with neurophysin 1 instead of neurophysin 2. So neurophysin 2 with ADH, neurophysin 1 with oxytocin. And it's stimulated mainly by two ways, either the stretch of the cervix, usually that's during birth, or through suckling. So basically, when the cervix is stretched or the uterus is stretched, this causes oxytocin to be released, which is going to cause contractions of the uterus during labor to help labor, basically. And then these increased contractions are going to cause more stretch, that's going to cause more oxytocin. So it's basically a positive feedback cycle. So more stretch, more oxytocin, contraction, stretch, and so on. However, it does not induce labor. It's not found to induce labor, but just helps or augments it, basically. It is also stimulated by estrogen. So that is during any birth. And it's inhibited by progesterone, which is, how do I remember this? Is that sometimes they even give like pregnant women who have preterm labor, they give them progesterone to inhibit the contractions. So progesterone inhibits oxytocin while estrogen is going to induce it. Again, as we said, suckling causes increased secretion of oxytocin. And oxytocin in the breasts, it causes the contraction of myoepithelial cells that causes the milk to be ejected. So it does not produce the milk, but it causes the milk letdown reflex. So yeah, that's basically it for oxytocin. So now moving on to the next question. If you guys have any questions, please stop me at any time. You can either unmute yourself or type it in the chat. Okay. So the next question is, a major league baseball player takes human growth hormone to increase his performance. Which of the following is true regarding human growth hormone? Increase, okay, stimulates, yes, yes, okay. So basically, growth hormone is produced by the somatotrophs in the anterior pituitary gland, and it's under the stimulation of growth hormone releasing hormone, which is released from the hypothalamus, and it's inhibited by somatostatin, or sometimes they call it growth hormone inhibiting hormone. I don't know why this was very important, but basically it's similar in structure to human placental lactogen, and in some areas they also say it has similar structure to prolactin. And in the blood, to increase its half-life, it binds to growth hormone binding proteins, GHBP, and it acts through, when it binds to its receptors, which are the growth hormone receptors, it acts through a JAK-STAT signaling pathway. It's called JAK-STAT. And growth hormone is increased during sleep. So it has the highest release during sleep. So if you sleep more, or if you slept more, maybe you'd grow taller. I don't know. So basically in the liver, when it binds to its receptors in the livers, it causes secretion of something called insulin growth factor 1. And insulin growth factor 1 are going to do the same actions as growth hormone around the body, and also bind to something called insulin growth factor binding protein. However, this insulin growth factor 1 is going to go back and it's going to inhibit, basically cause a negative feedback cycle inhibition to inhibit the release of growth hormone, and it also increases the release of somatostatin to inhibit growth hormone. So the main actions of growth hormone, as you can see here, it goes to the adipose tissue and it increases lipolysis. So basically the goal of growth hormone is to increase the growth of the body, increase the growth of the bones and the muscles and so on. And it also, its other goal is to not use glucose. So how does it do that? So the first thing is that it causes lipolysis. So now you can use fat as a source of energy rather than sugar. At the same time, it's going to cause glucose to increase in the blood because you're not using it anymore. So it doesn't let it go into the cell. And it causes insulin resistance. And it also breaks down glycogen to make it glucose. So you're going to have increased glucose in the blood and lipolysis. And then it increases the absorption of amino acids in the blood because you need amino acids to make proteins, and you need proteins to grow your muscles and bones and so on. So, and it enhances the proliferation. So that's basically it. For the pathologies, basically, if you have excess growth hormone in childhood, it causes gigantism, so you're very tall. And if you have excess after your bones are already closed, so now you can't grow lengthwise, so you're going to kind of grow widthwise. So they're going to have like big foreheads, large hands, large feet, and so on. This is called acromegaly. And then if you have decreased growth hormone in childhood, you're going to present with dwarfism, pituitary dwarfism. And sometimes the issue is not in the amount of growth hormone secreted, but in the receptor. And this is called Laron syndrome. So patients with Laron syndrome, they have a mutation in their receptor. So even though they have the growth hormone, they're not able to produce it. So they'll also be short, basically. So yeah, that's for growth hormone. The next question. A 49-year-old male patient with AIDS and declining CD4 counts has an increased frequency of infections and develops sick euthyroid syndrome with a decline in T4 and T3 levels with normal thyroid function. Which of the following is correct? Okay, yeah, that is correct. So basically, I'm just going to give a very brief of thyroid because it's going to be explained later. But basically, thyroid stimulating hormone is secreted by thyrotropes under the stimulation of thyroid releasing hormone from the hypothalamus, and it's inhibited by somatostatin, just like growth hormone. And TSH is made up of an alpha subunit and a beta subunit, and it shares its alpha subunit with LH and FSH, but the beta is unique. And then it's going to go to the thyroid glands and release T3 and T4, which are going to do their actions in the body. And then T3 and T4 are going to have a negative feedback inhibition on TSH and TRH, while TSH is going to have a negative feedback inhibition on TRH. Okay. So next question. A 45-year-old woman has a mass in the sella turcica that compresses the portal vessels, disrupting pituitary access to hypothalamic secretions. The secretion rate of which of the following hormones would most likely increase in this patient? C, C, C. Okay, yeah, perfect. So it is C, and why is that? We're going to see in a bit. So basically, prolactin is secreted by lactotrophs, and it's not part of an endocrine axis. Basically, instead of mainly stimulating signals, it has inhibiting signals, which is dopamine, or sometimes it's called prolactin inhibiting hormone. So dopamine is released from the hypothalamus, and it's going to inhibit prolactin secretion. So basically, in the previous question, if we basically disrupted this axis, no more dopamine would be going to the anterior pituitary, which is going to cause increased prolactin secretion, which is going to be the opposite for the other things because they all need stimulation. So prolactin will be the ones increasing while the other hormones are going to be decreased. But it has many other stimulating factors. During pregnancy, for example, estrogen, it's going to increase prolactin, but it also has an inhibitory method to prevent prolactin from producing the milk, but it's going to increase the levels of prolactin. Again, suckling is also going to increase the levels of prolactin to produce more milk. However, this is all in like pregnant or lactating mothers. However, in a normal individual, stress or sleep are some stimulating factors for prolactin secretion. Another stimulating thing is the thyroid releasing hormone, TRH, also stimulates prolactin. And there's some evidence of something called prolactin releasing factor, but honestly, I'm not sure. He had it bolded, so I added it. But yeah. Another thing about prolactin is that it can inhibit FSH and LH, which we're going to see now. But basically, by inhibiting FSH and LH, it's going to disrupt that axis. And that's why sometimes if, like they say that if you lactate regularly, if you breastfeed regularly, you can, it's a good method of contraception because it's going to inhibit FSH and LH. Another thing we said already causes milk production, and prolactinoma, which is a tumor in the pituitary gland that's going to secrete prolactin. That is the most common type of pituitary adenoma. So yeah. They'll present with things like galactorrhea, so they're going to produce milk even though, for example, they're not pregnant. Males can present with gynecomastia, so they'll have like breast tissue and so on. Okay, next question. Which of the following functions of Sertoli cells mediates negative feedback control of FSH secretion? Okay, yes, perfect. So it is inhibin. We're going to see now. So basically, FSH and LH are going to be secreted by gonadotrophs under the stimulation of gonadotropin releasing hormone, not GHRH, GnRH, okay? And then they're going to increase thyroid synthesis, which is going to increase gametogenesis. So they go to the gonads, which are the testes in males and ovaries in females. And in the testes, they're going to increase the secretion of testosterone. In the ovaries, they're going to increase the secretion of estrogen and progesterone. Okay. However, FSH and only FSH is going to cause the secretion of inhibin, and inhibin is going to inhibit only FSH, not LH. And FSH and LH are both present in the same cell, but they're in different secretory vesicles, you can say, and it depends on how much stimulation they get from GnRH for basically for the cell to decide whether to release LH or FSH, and that's all in like the menstrual cycle kind of thing. So yeah, that's basically it. Okay, so next question. A patient with a dislocated shoulder had it corrected under conscious sedation. The anesthesia drug that was used is known to impair the function of the pituitary adrenal axis. Hence, 1 week later, the patient's adrenocorticotropic hormone and cortisol were measured in blood samples taken at the indicated times. Which of the following is the correct conclusion from the patient data? It's a bit of a longer question. We'll wait to see people's answers. Okay, so 2 people said B, so yeah. Okay, mashallah. Yeah, that is correct. So as you can see, the values are all within the normal values, so there is no insufficiency or increase basically. But we're going to see that adrenocortical hormones are usually higher during the early morning and then they're lower at night, which is the opposite here because it's the highest at night, which shouldn't be. Okay, so we're going to see. So basically, ACTH is secreted by corticotropes under the stimulation of corticotropin releasing hormone. And this hormone in the hypothalamus is synthesized in something called the parvocellular neurons. And CRH, when it goes to the anterior pituitary, it's going to secrete everything as a big molecule, a prohormone called pro-opiomelanocortin, POMC. And POMC has the ACTH part, which is going to cause our the stimulation of cortisol and corticosterone and androgens in the adrenals. And another hormone, which is called melanocyte stimulating hormone or MSH, which is going to be important upcoming later, but basically stimulates the synthesis of melanin, which is the pigment of the skin. ACTH is going to bind to melanocortin 2 receptors in the adrenal cortex, which is then, as we said, going to stimulate the secretion of cortisol. And then cortisol is going to inhibit ACTH and corticotropin releasing hormone. And as we said, ACTH is secreted in a pulsatile manner and it peaks early morning and it's low at night, which is the opposite of what was here. So yeah, that's basically it. Khalid, you can share now. Do you guys have any questions? It's very brief. Okay. Okay. Problems.
Hello guys, can you guys see my screen?
Yes.
Okay, so first question. Inhibition of the iodide pump would be expected to cause which change? You have a B, B, B. Okay, yes. Good job, guys. So let's just quickly review the synthesis of thyroid, which is an important topic. So the first step is that iodide is actively transported into the thyroid cells via the NIS channel. And then from there, it goes to the lumen via the pendrin channel. And then it's this third step is called uh, or, or oxidation of iodine. So basically, two iodide ions are joined to form iodine. And then organification, which is addition of this iodine into thyroglobulin molecules. And once I2 is added to thyroglobulin molecules, which basically holds a lot of tyrosine amino acid together, you form MIT and DIT, which is monoiodotyrosine and diiodotyrosine. And then these two are joined or coupled to form either T3 or T4. So if an MIT and a DIT were joined, they'd form a T3. And if a DIT and a DIT were joined, they'd form T4. And then the thyroglobulin goes back in via penocytosis, and it will get the T3 and T4 will be broken off from the thyroglobulin molecule and then released by exocytosis. The MIT and the DIT will be deionated, and then you're back to just thyroglobulin, and then the cycle happens again. Okay, so it's important to note as well that all of these reactions, the oxidation, organification, and coupling, are done by thyroid peroxidase or TPO. So that's a very important enzyme for thyroid production. Now, if the iodide, this is the iodide pump. If this is not working, then the thyroid gland will try to compensate by adding more thyroglobulin molecules because it would want to make use of any iodide that's coming in. How does it do that? By increasing the number of thyroglobulin molecules. And whenever you're stuck, obviously just use elimination. So the first option says increase synthesis of T4, which is not possible because you have less iodine now. Increase the metabolic rate, that's also not possible. And decrease TSH secretion, opposite. There will be an increased TSH secretion, which is the cause of the increased synthesis of thyroglobulin. Okay, that's to compensate for the low iodine. All clear? Okay, the second question, TSH secretion from the anterior pituitary will result in which of the following actions on the thyroid gland? We have A. We have 1B. Okay, good. The answer is actually B. So let's see why. So first, this is the hypothalamus pituitary thyroid axis that Shaimaa spoke about. The hypothalamus releases TRH that will stimulate the anterior pituitary to release TSH, and that will stimulate the thyroid to release more T3 and T4. T3 and T4 have a feedback inhibition effect on the anterior pituitary and the hypothalamus. So if there's a lot of T3 and T4, it will inhibit the secretion of both TSH and TRH. Okay, so the function of the TSH on the thyroid gland, it has 5 functions. One is that it increases the number of the thyroid follicles, which is the most important effect of TSH. And this is actually the cause of goiter once you have excess TSH. That's why you get a goiter, because it increases the number of thyroid follicles and therefore increases the size of the gland. That's why it's called a tropic hormone. The second effect is that it increases iodine trapping, and it does that by increasing the expression of the NIS channels that we spoke about. That was on the basolateral membrane. It also increases the thyroglobulin proteolysis. It increases peroxidase activity, which we said was the most important enzyme, and it changes follicular cells from cuboidal to columnar, because the columnar is larger in size and it can absorb more, and that's why it makes it columnar instead. So in patients with excess TSH or TSI in case of Graves' disease, you'll see that the thyroid gland the thyroid cells became columnar instead of cuboidal. Now, for this question, deiodinase comes in the peripheral tissues, okay, or in the CNS, where T3 is converted into T4. I mean, T4 is converted into T3, the more active form of thyroid. That's where deiodinase mainly plays a role. So TSH doesn't have an effect on peripheral tissues. It has an effect on thyroid only. And these are the 5 effects that TSH has on the thyroid gland. Is this clear, Yasser and Abdulrahman?
It's clear, but can you hear me?
Yeah, I can hear you.
It's clear, but I think maybe the wording of the answer is a little confusing for A, لأن deiodinase, I thought it was the one that recycles the MIT with DIT into thyroglobulin.
Okay, so there are صح عليك. I should have added 5' deiodinase because that one is only in the peripheral tissues. But generally speaking, whenever you see TSH, think increased size or increased number of cells. That's the more prominent function of TSH.
مظبوط شكرا.
Okay, the next question. Congenital deficiency, Congenital deficiency of type 2 deiodinase will most likely lead to which of the following? I'm assuming you already saw the answer. Okay, can anyone tell me why, طيب?
Can I answer?
Yeah, of course, go ahead.
Because there's actually three types of peripheral deiodinase. في اللي هو type 1 و type 2 و type 3. Type 2 هو اللي يستخدم ال CNS and it has a very high affinity so as to kind of stabilize thyroid hormone levels in the case of hyper or hypothyroidism.
Perfect. And where do we find type 1?
Type 1, we find it in areas with high blood flow, like the kidneys and the liver.
So in peripheral tissues?
Yeah, peripheral tissue.
Then
Yeah.
what about type 3?
Type 3 is present in peripheral tissue, and what it does is it creates اللي هو reverse, so inactive form of T3 to counteract hyperthyroidism.
Yeah, so it's reverse T3 is the non-active form of thyroid hormone. Good job, Mumtaz. So first, let's just give an overview about the functions of the thyroid in the body. So the active form is T3. It's much more potent than T4. However, when secreted from the thyroid gland, 90% is T4, not T3, and it needs to be converted into T3. And that is because T4 has a higher or longer half-life in the blood, so it can stay longer in the blood. Secondly, because you don't want a lot of active thyroid in the blood. You just want it to be activated where you need it, صح? And that's why it's secreted in its less active form and the form that can stay longer in the blood. And then once it's needed, it's converted into T3, which has a very short half-life in the blood. It can't stay in the blood for a long time, but is much more active than T4. Okay. So the effects include, obviously, it helps in growth. It helps in the maturation of the CNS. It's very important, the maturation of CNS. It controls the basal metabolic rate. So thyroid hormone increases the activity of the sodium potassium pump, which is the main thing that controls the basal metabolic rate. If you increase the activity of the sodium potassium pump, you're increasing heat production because of burning of a lot of ATP. You're increasing oxygen consumption, and you're increasing the basal metabolic rate. And then for metabolism, it increases glucose absorption, glyconeogenesis, gluconeogenesis, and lipolysis. So it's mostly catabolic. And finally, it increases the protein synthesis and degradation, both. But generally, I mean, there's a net catabolic effect. So it breaks more protein than it makes. So in general, it's a catabolic hormone. And finally, in the cardiovascular system, it increases cardiac output. Now, this is what Abdulrahman explained perfectly, mashallah. thyroid or T4 is converted via three enzymes. There's deiodinase type 1, type 2. Type 1 is found in the peripheral tissues with high blood flow like the liver and the kidney. And type 2 is found in the CNS, and it has very high affinity, as Abdurrahman said, to control the levels of thyroid in the brain. And type 3 converts T4 into reverse T3, which is the inactive form, which is also one of the mechanisms to control hyperthyroidism. Next question. A 75-year-old woman comes to the office after 2 months of heat intolerance, sweating, and palpitation. The patient has lost significant weight recently despite increasing her dietary intake. Her TSH level is low. Which of the following lab findings is expected in this patient? Graves' disease, no? Maybe. So what's the answer? Okay, so we have one B, another B. Okay, we have all Bs. You're correct. It's high levels of TSI. As Yasser said, this is a diagnosis of Graves' disease. We'll talk in detail in a bit. Which finding is most likely in a patient who has mixed edema? So you have a patient who has mixed edema. A, excellent. Okay, good job. And what's the diagnosis? Probably if you see mixed edema. Hypothyroidism, another name for the disease. Hashimoto, good job. Good job, guys. So just to briefly summarize, because it's obvious you guys know it well, mashallah. For hyperthyroidism, the disease you guys have to know is called Graves' disease. The cause is an autoimmune activation of thyroid gland via thyroid stimulating immunoglobulin. A lot of you get confused. They think that this immunoglobulin, since it's autoimmune, it attacks the thyroid gland. I saw a lot of people debating about it on your group, but it doesn't attack the thyroid gland. It stimulates it. It acts exactly like TSH. Okay. And for the labs, you'll find low TSH. As soon as you see patient with hyperthyroidism symptoms, but with low TSH, you know that's the Graves automatically. Okay. And this is because of the feedback inhibition we spoke about of T4 on the hypothalamus and the anterior pituitary gland. You'll find high T3 and T4 levels, obviously, by definition. Classical presentation would be exophthalmos, which is protruding of the eyes, and you'll see a goiter due to tropic action of TSI. Now, for again, this is a confusing point for some people. They'll say, no, since we have low TSH, how do we have a goiter? It's because TSI has the exact same function of TSH. For Hashimoto's or hypothyroidism, this is also autoimmune, but this time it's a destruction of the thyroid gland. It's not stimulation of the thyroid gland. And since the thyroid gland is now being destroyed, there's going to be low levels of T3 and T4. And because of that, again, the loop, it will tell the pituitary to secrete more TSH since there's low T3 and T4. So hypothyroidism with high TSH is probably Hashimoto's. Classical presentation is mixed edema, which is the swelling around the eyes. So that's different from protruding of the eyes. Swelling around the eyes is different from the eyes coming out, okay? And again, you'll see a goiter, but this time it's due to high TSH levels, okay? So one might ask, since we have high TSH and the thyroid gland is actually responding and it's becoming big, why don't we have normal T3 and T4 levels? It's because even though the thyroglobulin is increasing in number, that doesn't mean that the thyroid gland can still secrete normal T3 and T4 because it's still being destroyed. Okay, so that's why we see the goiter although we have hypothyroidism. As for the symptoms of hyper and hypothyroidism, for hyperthyroidism, as we said, it's catabolic, so you'll see weight loss, you'll see increased appetite, heat intolerance, diarrhea, anxiety, and nervousness, and tachycardia and palpitations. So it's obvious. Hyperexcitation is hyperthyroidism. Hypoexcitation, so sleep, weight gain, decreased appetite, cold intolerance, and stuff like that. That's all hypothyroidism. It's obvious once you see in the presentation whether it's hypo or hyperthyroidism. And okay, so I think that's it for the thyroid. Shaimaa, does anyone have any questions? Okay.
That's pretty clear.
Okay. So the first question is, an increase in serum levels of which of the following electrolytes will increase aldosterone secretion? Wait, sorry, I don't have chat open. 1 second. Okay. Um, okay. Answers? Anyone? Okay. So there's a D in the chat, and yes, that is correct. So basically, we're going to see just a quick overview of the adrenal gland. So as you can see, the adrenal glands are suprarenal glands, 2 glands on top of the kidneys, and they have 3 layers. So basically, there's a cortex and there's a medulla, and the cortex is made up of 3 layers: the zona glomerulosa, zona fasciculata, and zona reticularis. And you can remember the order as GFR. And basically, each one of them secretes a certain type of hormone. So glomerulosa is going to secrete the aldosterone, and fasciculata is going to secrete the cortisol, and reticularis is going to secrete the androgens. And then the medulla has the chromaffin cells, which are going to secrete the norepinephrine and epinephrine, which are the catecholamines. And from like just the quick embryology, the cortex is from the mesoderm, and the medulla is neural crest cells, which make cells because it's secreting basically like neurotransmitters, kind of. Okay, so the aldosterone, like each hormone, so aldosterone, it basically works on the sodium-potassium exchanger. So it's going to increase sodium absorption and increase potassium excretion. So here, even though it's not the exact same weight, sorry, it's not the same exact logic, because here potassium causes depolarization, but even then, increased level of potassium are going to kind of make the aldosterone push it out, basically, because that's the function of aldosterone, pushing out potassium and absorbing sodium, okay? And what comes with sodium? Water. So basically, the end goal of aldosterone is to bring in water to increase the blood pressure, okay? And how does aldosterone, how is it stimulated? By the RAS system, the renin-angiotensin-aldosterone system, okay? Specifically by angiotensin 2. So increased angiotensin 2 is going to cause aldosterone synthesis and secretion. This is going to, as we said, is going to bring in the sodium and push out the potassium. And it's inhibited by the atrial natriuretic peptide, which we also mentioned before. We said that ANP also inhibits ADH. So basically ANP, natriuretic, it wants to push out sodium. So it's going to inhibit the thing that's going to basically oppose its action again, because it wants to keep the blood volume low. The other hormone, which is cortisol. So cortisol is a stress hormone. It has many functions. As you can see here, a big fib. It increases appetite, increases blood pressure by either upregulating the alpha receptors, or it can also, at high concentration, bind to the mineralocorticoid receptors and have the same actions of aldosterone, okay? It also increases insulin resistance, which is going to increase glucose, again, increases gluconeogenesis, again, which increases glucose, lipolysis. These this is like similar to growth hormone. However, it causes proteolysis, so it causes protein breakdown, unlike growth hormone. And it also decreases fibroblast activity. So it has basically doesn't really synthesize things. So you're going to have delayed wound healing and so on, thin skin, which we're going to see later. And it also going to decrease the inflammation and decrease immune cells. Therefore, it causes immunosuppression and also decreases bone formation. Again, opposite of growth hormone. However, it's also like a stress hormone. Cortisol is stimulated by ACTH and it's produced in the zona. See, I forgot myself. Okay, so cortisol is in the zona fasciculata and aldosterone is in the zona glomerulosa. Okay, and it's stimulated by ACTH. And as we said, the ACTH is secreted in the pulsatile diurnal pattern. As we said, it's high in the morning and low in the evening. And then cortisol itself is going to inhibit ACTH. And then we have androgens, which are secreted by the zona reticularis, again stimulated by ACTH. So ACTH stimulates to androgens and cortisol, not really aldosterone. Aldosterone is by the renin-angiotensin aldosterone system, okay? And androgens is mainly for females because in the males, it's mainly produced by their gonads. However, in early, when the person is still a fetus, then it's still the main, even for male or female. Okay. So next question. A 15-year-old girl presents with a 3-week history of nausea and 2 months of unexpected weight loss. Menarche has not yet occurred. Her physical examination reveals immature secondary sexual development. Her temperature is normal. Her pulse is 72 beats per minute. Her respiratory rate is 14. Her blood pressure is 138/89. Her gums are hyperpigmented. Lab tests reveal hypernatremia, hypokalemia, and low fasting blood glucose. Results from the blood test show an increased titer of autoantibodies that block the normal action of the target antigen. Which of the following antibodies is most likely found? Bit of a difficult question. Is someone saying D? Someone else. Okay. Mashallah then. Guess it's not so. So yes, this is anti-17 alpha hydroxylase. So if we can see here, this is the synthesis pathway of the steroid. And I'm just going to go over the main enzymes. So we have the cholesterol desmolase. This is the main thing that's going to convert cholesterol to pregnenolone. Okay. So this is the step that's activated by ACTH. And then after that, pregnenolone can be converted to 17-hydroxypregnenolone or DHA. So basically, to move from this is like the synthesis of mineralocorticoid, this is of glucocorticoids and androgens. To move from mineralocorticoids to glucocorticoids and androgen, you need 17-alpha hydroxylase. If you do not have 17-alpha hydroxylase, you cannot produce glucocorticoids and you cannot produce androgens, okay? Except corticosterone. So corticosterone is also considered a glucocorticoid, but it's a weaker one. But you can produce cortisol, okay? And then we have the 21 alpha hydroxylase. This one also, it basically converts from the progesterone states to give us either the mineralocorticoids or the glucocorticoids. So if we don't have this, we can't produce these, but we can produce androgens, okay? And 11 beta hydroxylase, the same thing is we can't produce the mineralocorticoids or glucocorticoids. But we can produce the androgens. However, another thing here is that 11-deoxycorticosterone is also a weak mineralocorticoid. So corticosterone is a weak glucocorticoid and 11-deoxycorticosterone is a weak mineralocorticoid. So even if we have 11 beta hydroxylase absent, we're still able to have mineralocorticoid activity. And we're going to go into the bit more details right now. So any deficiency in one of these enzymes leads to something called congenital adrenal hyperplasia, because in the end, all of them are going to lead to a decrease in the levels of cortisol. And cortisol is the main inhibitor of ACTH. So if you don't have cortisol, your pituitary gland is going to continue on secreting ACTH, ACTH, and ACTH. And just like TSH, which was mentioned before, this has a trophic effect on the adrenal gland. So it's going to cause hyperplasia. That's why it's called congenital adrenal hyperplasia. So they have enzyme deficiencies. However, the glands are going to be enlarged. Okay. And if you know, as we mentioned before, that ACTH is not secreted directly as ACTH, it's secreted as a molecule called POMC. And POMC gives you ACTH and something called MSH, which is going to increase the melanin production, which can lead to hyperpigmentation if it's high, if it's in high levels. Okay. So basically, in congenital adrenal hyperplasia, you're going to have decreased cortisol, and then either like a defect in one of the others. Usually they'll present with atypical genitalia. They're all autosomal recessive diseases, and they will usually again present with hyperpigmentation because of the increased MSH, which was mentioned here. Her gums were hyperpigmented. Okay. So the most common one of them, though, is the 21-hydroxylase deficiency. So as we said, in 21-hydroxylase, you have deficiency of mineralocorticoids and glucocorticoids, but you're going to have excess androgens. What does excess androgens do? It's going to cause virilization of the female genitalia. So they're going to have clitoromegaly, a lot of hair, and so on. So basically that's for 21-hydroxylase because of the excess androgens. Because as we said, ACTH is going to also stimulate the androgen secretion. So the more ACTH there is, the more androgen is going to be secreted. The next one is the 11-beta-hydroxylase. So 11-beta-hydroxylase, as we said, you're going to have decreased aldosterone and glucocorticoids. However, you're going to have mineralocorticoids, which is the 11-deoxycorticosterone. And why is that important? Because again, there's going to be increased stimulation of ACTH. And even though this is a weak mineralocorticoid, this is still going to have a very strong effect because it's going to be in high numbers, which is going to cause sodium retention and hypertension and so on, which is the opposite here, because when we don't have any mineralocorticoids, we're going to lose all that salt. We're not going to be able to retain sodium, and therefore it's called salt wasting, and it will not have hypertension. But with the 11, because you have the 11-deoxycorticosterone, you're going to have the mineralocorticoid effect, which is going to cause the hypertension and sodium retention. And also, again, with it, you're going to have the increased androgen, which is going to cause female virilization. However, in 17-alpha-hydroxylase, you're going to have normal mineralocorticoids. It's not affected. The only affected part is going to be the glucocorticoids and the androgens. So now that you have low androgens, you're not going to have female virilization. However, males can present with ambiguous genitalia because they're not able to produce the testosterone, basically. And yeah, so now a quick way to kind of remember it. And the enzyme begins with 1, like 11-beta or 17-alpha-hydroxylase, know that they're going to present with hypertension. Again, because the mineralocorticoids are working, so you can retain the sodium and cause increased blood volume. So if it starts with 1, there's hypertension. If it ends with 1, like 21-11-beta, there's female virilization, which means there's increased androgens. So if we, what was that? Okay, so if we see here, basically, she doesn't have enough androgens, which means it's 17-alpha-hydroxylase. And the blood pressure is high because there's hypernatremia, there's high blood pressure, and so on. Okay, so it can't be the 21. Okay, this is okay. So basically, this is like a summary table that has everything that shows the increase and decrease and the genitalia, which is a nice one. When you get it, you can just review it and you'll know everything. Okay, next question. A person experiencing which of the following situations would be expected to present with parallel changes in serum aldosterone and cortisol?
What do you mean parallel changes?
Like either both increased or both decreased or both are unaffected? Saying A. Okay, yes, that is correct. So it is Addison's disease. So what is Addison? Addison is a form of primary adrenal insufficiency. Okay, so basically here, usually due to like an autoimmune destruction of the adrenal glands, you're going to have decreased cortisol and aldosterone. Okay, and this decreased cortisol is going to go back to the brain. And since there's no negative feedback inhibition, there's going to be increased ACTH secretion, again causing increased melanocyte stimulating hormone, which is going to cause hyperpigmentation, just like in congenital adrenal hyperplasia. So there's primary or secondary or tertiary, depending on what level the insufficiency is in. So primary adrenal insufficiency, the problem is in the adrenal gland itself, and it can either be acute or chronic. So chronic, as we said, Addison, which is the most common, and it's usually due to either autoimmune. However, acute is usually due to hemorrhage after an infection with a specific bacteria called Neisseria meningitidis, which usually causes meningitis, and this is called Waterhouse-Friderichsen syndrome. So Waterhouse-Friderichsen syndrome is usually acute primary adrenal insufficiency, usually fatal. The patient will die, unfortunately. Then we have the secondary adrenal insufficiency, which is now the problem is in the pituitary. So there might be a pituitary adenoma or something or some sort of pan-hypopituitarism. So basically, there's going to be decreased ACTH secretion. Here, we're not going to have hyperpigmentation because there's no secretion of MSH. So again, ACTH will be low and cortisol will also be low. Then we have the tertiary. So tertiary, now the problem goes even higher up in the hypothalamus. Usually, this is due to a person who took cortisol or external steroids for a very long time and then suddenly stopped them. And because while he was taking the cortisol, there was constant inhibition on the CRH and ACTH. When they suddenly stopped them, there was no release, and therefore they're going to have adrenal insufficiency. And that's why you don't stop cortisol like suddenly. You always have to taper it down to give time for the hypothalamus pituitary adrenal axis to work back. So yeah, basically these are just like tertiary is usually from treatment. Primary pigments usually in, like as we said, in increased MSH in the chronic one. Okay. This is basically a quick summary again. No, wait. I think. Okay. Never mind. Okay, yeah. So that's a quick summary. Okay. So next question. The husband of a 63-year-old woman reports that his wife's personality has significantly changed over the past 2 years. Upon investigation, the woman also admits to having memory problems. Physical examination reveals centralized obesity, round face, thin limbs. Lab results show fasting hyperglycemia. The ACTH and the cortisol is shown on the graph. Serum ACTH is measured every 10 minutes for 1 hour, and CRH is infused at the time of the arrows. Which of the following is the most likely diagnosis? So this is of the patient. I don't know. Where's the opposite? Okay. Cushing's disease. Okay. Yes. So this could have also gotten from the symptoms. So what is Cushing disease or Cushing syndrome or hypercortisolism? So it's basically increase in cortisol. However, this we could divide it into either ACTH dependent or ACTH independent. So ACTH dependent, that means that we have ACTH, that increased ACTH that's being secreted, that's causing increased cortisol secretion. So what can cause this? Either something called Cushing disease, which means the problem is with the pituitary gland itself, and we're secreting a lot of ACTH that's secreting a lot of cortisol. That's basically it, okay? then we can either have ectopic secretion, usually from lung cancer, that's going to secrete ACTH, which then causes increased cortisol, okay? However, ACTH independence, that means that cortisol from itself is high, even though ACTH levels are low. So what can cause this? Either an adrenal tumor, cortical tumor that's causing, like it's releasing cortisol from itself, and usually it's going to negatively inhibit the pituitary, so there's going to be no ACTH secretion. Or, which is the most common cause of Cushing's, is external steroids. So someone is taking steroids, that's causing Cushing. And they'll usually present with these symptoms: moon face, striae, weight gain, truncal obesity, buffalo hump, diabetes, hypertension, insulin resistance, osteoporosis. It's very bad. Steroids are very bad. Okay. So basically, there are like some ways to be able to differentiate whether it's ACTH dependent or ACTH independent. So first of all, you want to confirm, is this actually hypercortisolism? So how do you do that? You measure the 24-hour urine free cortisols, you find them high, okay. You do ACTH levels. If you find that they're high, then this is ACTH dependent. If you find that they're low, then this is ACTH independent, okay? Then again, this low dose, basically, dexamethasone is similar to cortisol. If you give it, it should cause inhibition of ACTH, which should cause inhibition of cortisol. So if there's no inhibition, that means you have Cushing's. However, high dose, if you give very high doses of dexamethasone and cortisol is inhibited, that means that ACTH secretion was decreased a little bit. So that means that the ACTH came from the pituitary. However, if the ACTH was ectopic, it's not going to react to dexamethasone, whether it's high or low, okay? But if it came from the pituitary, it's going to react to high levels of dexamethasone. And then another thing is CRH. So CRH is released by the hypothalamus. If the levels of cortisol increase if you give CRH, again, it means it's from the pituitary, because that means it's responding to both negative feedback and positive feedback. But if it's ectopic, it's not going to. And of course, imaging to see if there's any pituitary tumor, adrenal tumor, and so on. Okay. So again, this is like a quick summary. So if this is the normal, ACTH levels are normal. There is low cortisol with both low dose dexamethasone and with both high dexamethasone. And if you gave CRH, it's going to increase. However, this one, when there's low ACTH, that means it's ACTH independent, and there is no response to the low dexamethasone, no response. This is, both of them is for when the ACTH levels are high. And there's no history of someone taking steroids, then you might think, okay, this is adrenal tumor. However, if there's history of someone taking steroids, you might think, okay, this is exogenous steroids. If the ACTH is high and the high dose makes it basically cause decreased cortisol, this is from the ACTH, from the pituitary, I mean, and this is Cushing disease. Cushing disease is only when it's from the pituitary. However, there's no response to the dexamethasone or CRH, nothing. This is ectopic. So that's basically it for cortisol. So yeah, these are just the answers. Okay. So next question. A 50-year-old man presents with headaches and weakness for several weeks. On investigation, he is hypertensive and hypokalemic. Serum aldosterone is elevated. The result shows an adenoma in the adrenal zona glomerulosa. So primary hyperaldosteronism is suspected. Additional tests are ordered. Which of the following changes to serum renin and serum angiotensin II would support the initial diagnosis? Okay. I'm saying D, someone is saying A, B. Oh, there's a lot of different answers. Okay, so they have primary hyperaldosteronism. So there's high aldosterone, which causes increased blood volume, which causes increased blood pressure. So how would the renin angiotensin system act? Would it be increased or would it be decreased? B, okay, yes. So the answer is B. So what is hyperaldosteronism? It's increased aldosterone, and it can either be primary or secondary. Primary, usually to the adrenal adenoma, as we mentioned before, and this is called Conn's syndrome. Okay. So this is like autonomic. Basically, the aldosterone is just increased. However, in secondary, usually due to, for example, renal artery stenosis or a renin tumor, there's basically increased aldosterone due to increased RAS activation system. So here it's going to be the opposite. Here it's going to be, in secondary, there's going to be high renin and high angiotensin. And it's the opposite in primary. So they'll usually present with hypertension because there's increased absorption of water. But not with increased sodium, because there's something called sodium escape. So sodium will be able to leave the body, but they're going to have hypertension. And because they're taking in sodium and excreting the potassium, they're going to have hypokalemia. So if you see a picture of hypertension with hypokalemia, think increased aldosterone. That's usually the case. So yeah, as we said, in primary, there is low renin, and in secondary, there is high renin, because the high renin is the one that's causing the hyperaldosteronism. Okay, next question. A 31-year-old woman presents with episodes of hypertension, nervousness, irritability, panic attacks, and constipation for 4 months. She complains of sweating more than normal, even at night. A CT scan is performed revealing a functional tumor. Based on the signs and symptoms, where is it most likely located? And give me the name. B. Okay, there's one B. And the name, if it's B. Okay, so yeah, it is B. The symptoms are hypertension, nervousness, panic attacks. These are increased with epinephrine, norepinephrine, and it is pheochromocytoma, so in the adrenal medulla. So basically, this is like a quick, because I love this thing, but basically, the sympathetic preganglionic fibers are going to go to the medulla, release their acetylcholine, which are going to cause the secretion. Basically, this is in the normal neurons, but in the adrenal glands, the secretion of acetylcholine is going to cause the release of epinephrine and norepinephrine. So basically, the adrenal medulla is acting as a ganglion. And then epinephrine and norepinephrine, as we know, cause the sympathetic system. And usually when they have pheochromocytoma, it's fluctuating. So it's not always high, but it's released in like, sometimes it's high and then it goes low and then it goes high again. Okay. So basically, what are the actions? So depending on whether they're binding to alpha or beta receptors. So if you can see here, alpha is usually present in the arteries or smooth muscles. Beta is usually present in beats or breaths. Beats is the heart, breaths is the lungs, okay? And then depending on either is it 1 or 2, 1 usually contracts and 2 dilates. So alpha 1 is going to cause vasoconstriction. Alpha 2 is usually present in the presynaptic membranes, and it causes the opposite of sympathetic effect. It inhibits release of norepinephrine, so it will cause, you can say, dilation of the smooth muscles instead of the arteries. Beta 1, we have only one heart, so beta 1 is present in the heart, and it's going to cause increased contraction, increased contractility, because it's 1. And beta 2 is present in the lungs, so it's going to cause bronchodilation because it's number 2, okay? And it also causes vasodilation in skeletal muscles, but that's fine, it's not important. Okay, so basically for pheochromocytoma, we said it's an neuroendocrine tumor of the medulla. It's going to cause increased epinephrine and norepinephrine. And basically, they're going to present with episodic hypertension. And also you can present with orthostatic hypotension. And why is that? Because the high amount of catecholamines that were released is going to cause downregulation of the receptors. Basically the alpha beta receptors, and when you stand up, your blood pressure goes down. But because they don't have enough receptors, and if at that moment they don't have enough of the catecholamines, their blood pressure is going to drop very low and they're going to have orthostatic hypotension. But usually they're going to present with the hypertension, sweating, panic attacks, palpitation, all the excessive sympathetic activities. Usually you'll find in their urine something called vanilla mandelic acid. I just remember it as vanilla. I see vanilla, it's Pheochromocytoma. And yeah, usually when you want to treat it, you're going to inhibit the alpha and then you're going to inhibit the beta. So A before B, because if you inhibit beta, all the catecholamines are going to bind to the alpha receptors and it can cause vasoconstriction, which can cause a hypertensive crisis. So you don't want that to happen. So you're going to first block the alpha so that the vessels have nothing, and then you block beta. And that's basically it for adrenocortical. Do you guys have any questions?
There was the question about whether someone has low renin and high aldosterone. How would it
Yes.
be both decreased?
So it wasn't aldosterone, it was angiotensin 2.
Angiotensin too. How would they both
Yeah.
be decreased?
Decreased? Okay.
Yeah,
Khalid,
how would they?
Yeah. So basically, renin stimulates angiotensin. Oh, wait. Sorry. Renin, the RAS system, renin stimulates the production of angiotensin, right?
Yes.
So if renin is high, then angiotensin will be high. Okay. And what's
Yes.
the ultimate goal of the RAS system? It's to increase the blood pressure. And renin also stimulates aldosterone. So renin stimulates angiotensin and stimulates aldosterone to increase the blood pressure. When there's a tumor in the adrenal glands, basically Conn's syndrome, it's producing aldosterone from its own, even without the stimulation from the renin and angiotensin, which we said that the main stimulation of aldosterone is the RAS system. So when aldosterone is being produced by its own, it's causing increased blood pressure because it increases sodium absorption, increases water and the blood volume, basically increasing the blood pressure. Now the RAS system is not working because there's high blood pressure. So RAS system will not work. So renin will be low and angiotensin will be low. But it's the opposite in secondary. So in secondary, the problem, for example, here, renal artery stenosis, there's decreased blood flow to the kidney. So the kidney thinks by mistake that there's low blood pressure. So when it thinks that there's low blood pressure, it's going to increase the synthesis of renin, which is going to increase synthesis of angiotensin and aldosterone. Therefore, aldosterone is also going to be high. So in both cases, you're going to find aldosterone high, but one of them is because renin is causing aldosterone to be high, and one of them is because aldosterone is high from its own. So in this case, because the blood pressure is high, renin will be low, and since renin is low, it's not going to stimulate angiotensin too, so it's also going to be low. I hope this made sense.
Yeah, tamam. Thank you so much.
Any other questions? Okay. Thank you.
Hello, guys. Can you see my screen?
The functions of TSH on thyroid, صح?
Okay. So let's start with the last couple of lectures on insulin, glucagon, and diabetes. The first question, which of the following is most likely to produce the greatest increase in insulin secretion? I have two B's. Okay, it's a straightforward question. Just to quickly remind you guys, the insulin synthesis and secretion. So basically, insulin, this is what's going to be insulin in the end. It's synthesized in rough endoplasmic reticulum, and then it's transported into the Golgi apparatus where the C-peptide is cleaved, and then you're left with insulin. So it's first pre-proinsulin, and then proinsulin, and then just insulin. And each time we're cutting something off. So the first time we're cutting the signal sequence, the second time we're cutting the C-peptide, and then we're left with insulin. Now, this is the important part, well, insulin secretion. So basically what happens is when there's glucose in the blood, there are highly sensitive channels for glucose, which is the GLUT2, and this is specifically found in the pancreas. Glucose enters and then it's broken down by glycolysis, and obviously this will produce ATP. Now, when there's high ATP because of glucose entering, we have channels that are called ATP sensitive potassium channels that will open once we have ATP. So when glucose enters, these channels will open, and then potassium will leave because potassium is more inside than outside. Potassium will leave, then that will cause depolarization of the membrane of these cells, normal beta cells of the islets of Langerhans in the pancreas. And this depolarization will open voltage-gated calcium channels, and then this will increase the intracellular calcium and will cause the exocytosis of insulin. Okay. Now, there is a lot of things that increase this secretion of insulin. They're all summarized in this table. So obviously, increased blood glucose because more glucose will be entering from this channel. Increased free fatty acids also because that's an indication that you just ate and you need insulin. Increased blood amino acids because again, that means you just ate and you need insulin. Gastrointestinal hormones like gastrin cholecystokinin or gastric inhibitory peptide. These are secreted from the GI once you eat. So again, that's an indication that you ate and you ate and you need insulin. Even glucagon stimulates insulin to some extent. Uh, that's okay. That's in order to not cause hypoglycemia or hyperglycemia. So when a lot of glucagon is secreted, that will cause hyperglycemia, صح? So you need some glucagon to stimulate some insulin in order to prevent hyperglycemia from happening. There's also parasympathetic stimulation from the nervous system, beta adrenergic stimulation, which is epinephrine and norepinephrine. And finally, insulin resistance or obesity, and we'll come to talk more about that later when we discuss diabetes. Now, what inhibits insulin from being secreted is obviously the opposite of all of those. Decreased blood glucose, fasting, because in fasting you won't have free fatty acids and you won't have amino acids in the blood. Somatostatin, this thing just inhibits everything, if you remember from GI as well. So it inhibits stuff in the pituitary, it inhibits stuff over here as well. And finally, alpha adrenergic activity. So beta adrenergic or beta receptors, they increase the insulin secretion. Alpha adrenergic will decrease. Okay, so the second question. So is this clear? The secretion of insulin is important. Is it clear? And what
Yeah,
things
it's
will
clear.
increase and what things will decrease? Next question. Which of the following pancreatic secretions has a receptor with 4 subunits, 2 of which have tyrosine kinase activity?
A.
Insulin. Yeah, fair enough. But what about glucagon? What's the receptor? Do you guys know? CAMP. Yeah, but what's the receptor? CAMP is the secondary messenger. Okay, so it's a G-coupled protein. Yeah. So that's the receptor for glucagon. For insulin, it's a receptor that's linked to tyrosine kinase and has 4 subunits. Okay, second question. A patient was diagnosed with a tumor of the B cells in the pancreas. Which of the following the patient most likely present with? We have 1D, Have another idea? Okay, so let's think again. What are B cells? What do they secrete? Oops, I didn't mean to show the answer. What are B cells? What do they secrete?
They secrete insulin.
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 So if you have a tumor of these cells, that means there is more of these cells. That doesn't mean there's damage to these cells. And so the body secretes more insulin, and it's called insulinoma, or tumor of insulin producing cells. Okay, so now would you guys reconsider your answer?
I wouldn't actually, and let me tell you why.
You
Because if I have increased insulin, then maybe the insulin receptors will start to become desensitized. I would have, I think it's type 1, I'm not too sure,
I think
which is
it
the
would be
type of
type
diabetes
2.
where, oh,
Type
type
2
2,
would
yeah,
be insulin resistant.
exactly. So I would have insulin resistance if I have high production of insulin, even when I don't need it.
Okay, that's a valid answer. But insulin resistance is a chronic condition. I'll explain it more in a bit. But it's a chronic condition, and you need to have high levels of insulin for a very long time. And it comes mostly with obesity, and genetic factors. But if you have a tumor that's secreting insulin, that's too much insulin, that won't cause resistance, that will cause acute presentation. Yani the patient will be will have neurological dysfunctions, diplopia, أشياء زي كده. It will be a very acute presentation because it's a tumor that's secreting a lot of insulin at once. But insulin resistance is you have slightly high, or yani high insulin, higher than usual insulin levels for a very long time, and there needs to be a problem with your receptors. You need to be either obese or have genetic disposing factors, and then insulin resistance will develop حتى over a very long time. يعني insulin resistance is a curve. It starts like this and then it goes up until you can call yourself insulin resistant. It will take years, not يعني it's not something that happens in 2 or 3 weeks. No. So that's why if you have an insulin producing tumor, then you won't get diabetes. You won't reach that stage أصلا. Is that clear? Well,
Yeah, that's good.
okay, so what's the answer now? Well, did you guys see it?
We saw the answer.
So it's hypokalemia. And can anyone tell me why? So just think about the functions of insulin. Let's look at them quickly. Obviously, insulin wants the glucose in, okay? It wants it inside the tissues. So it will increase uptake in almost all the tissues except the brain, because the brain is not insulin dependent. So it won't depend on insulin to uptake glucose. It will just be constantly uptaking glucose. But in other tissues like skeletal muscle and liver, they're insulin dependent. So when you have insulin, it will increase the glucose uptake. It will increase the glycogen synthesis once the glucose is inside. It will increase triglyceride synthesis. It's basically an anabolic protein. Anything that makes big chunks of stuff, that's insulin. Now, these are two important functions as well. It increases sodium retention, but more importantly, it increases cellular uptake of potassium and amino acids. So when you have excess insulin, especially when it's too much, like when it's being secreted from a tumor, then you'll have very low potassium levels in the blood because all the potassium will be sucked up by the cells. Okay? And that's why the answer over here is hypokalemia. It will obviously inhibit glucagon, and finally, it will inhibit lipolysis. And glucagon will have all the opposite of these effects. Now, this is the receptor we spoke about for insulin. It has 4 subunits. It's tyrosine kinase linked. Once tyrosine is phosphorylated, it will activate multiple pathways that will bring out these effects. Okay, whether it was secreting stuff or whether it was affecting the protein synthesis in the DNA of the cell. Now ايش كنت بقول انا هنا؟ Yeah, insulin resistance, Rahman, happens when these receptors are not are desensitized, as you said, but they don't become desensitized like that. There needs to be a cause, and mostly these receptors become phosphorylated all the time, so they're activated all the time. فخلاص, the cell doesn't respond to insulin. It was activated all the time anyway, and so insulin doesn't cause much difference. And these obviously can be genetic disposing factors or obesity, and because of obesity, aslan insulin is high all the time. Okay, and that's why you have insulin resistance. Next question. A man eats a low carbohydrate meal rich in proteins containing the amino acids that stimulate insulin secretion. Which of the following responses accounts for the absence of hypoglycemia? I touched upon this. Okay, the chat says D. Good job. So yeah, proteins, it's one of the things that increases the secretion of both glucagon and insulin. Okay, and also because since insulin is being secreted, it's also gonna somewhat increase the secretion of glucagon to not cause hypoglycemia. Good job. Next question. Which of the following pairs of hormones and the corresponding action is incorrect? Incorrect. We have one B. We have a D. We don't have a D. To B. Okay, so the answer is B. Good job, Haneen. Do you guys know why؟ احنا قلنا انه increased glycogenolysis is glucagon صح؟ بس the part that's wrong is skeletal muscle. Okay. Now this is very important, especially for your mole exam, but it's also important here. You need to know where hormones act. You don't only need to know the function, so you need to know where it acts. So if I tell you that insulin affects the brain, it doesn't, because the brain is not insulin dependent. صح? Even if I say it increases glucose uptake, yes, it does increase glucose uptake, but in the brain is wrong. You need to know which tissues the hormone acts on. Glucagon affects the liver mainly. Okay, it does not have an effect on skeletal muscles, has an effect on liver mainly. Okay, so this table is very nice. It summarizes the receptor, the signaling pathway, and the effects. As we can see, glucagon over here, it affects the liver. Epinephrine, on the other hand, helps glucagon with the liver, but also affects the muscle. Okay, there's a lot of things that act towards the pathway of glucagon epinephrine. That includes growth hormone and thyroid hormone, as we explained earlier. But you need to know for now that glucagon acts only on the liver. Epinephrine acts on both the liver and the muscle. Okay. Now this is the G-coupled receptor I told you about for glucagon, and it activates the CAMP pathway as a secondary messenger. Does anyone have any questions until now? It's pretty straightforward, the lecture. That's why I'm not taking too long on the questions. All clear?
Clear.
Now, I to touch up on this point again, the whole glucagonoma and insulinoma. These are tumors that happen in either A cells in case of glucagon or B cells in case of insulin. So the things you need to focus on the most is for glucagonoma, you'll find diabetes or hyperglycemic state. Okay, this is important. Glucagonoma is the one that causes diabetes. It's not insulinoma, and that's because it will cause a lot of glycogen breakdown and cause a lot of glucose release, and that's why it's the one that's going to cause diabetes or hyperglycemia. Don't get confused with this. Okay. It will also, a classical presentation is declining weight, and you might find, the patient came with a rash that might help, but mainly these are the things, they found a tumor, the patient was found to be in a hyperglycemic state or found to have diabetes even, and declining weight. So this is على طول glucagonoma. Okay. As for insulin, you'll have low blood glucose, obviously, because that's a function of insulin, and the symptoms of hypoglycemia, which is lethargy, syncope, and diplopia. And those are classic symptoms of hypoglycemia. Okay. And the C-peptide levels, that's how you can confirm the test. C-peptide levels are going to be extremely high. Now, I'm going to ask you a question. Why don't we use insulin as a measure for insulin levels in the blood? Why don't we measure insulin? Why do we measure C-peptide?
I think because in type 1 diabetes there would be a decreased amount of C-peptide.
Yes, but why? It's two reasons. One is C-peptide is only secreted from endogenous insulin. And if you take an insulin shot, you won't have C-peptide, okay? And so it's an indicator of how much insulin is being made inside the body. So a type 1 diabetic patient, one of the diagnosing criteria is low levels of C-peptide. That means the body is not secreting enough insulin, okay? Also, why we measure C-peptide and not insulin is because C-peptide has a very long half-life in the blood, and it can stay in the blood for a long time. Insulin has a short half-life, so it's not an accurate measure of how much insulin is being produced. Then as soon as it's produced, على طول it's taken up, it's depleted, it's broken down. You don't want insulin to be elevated in your body, and that's why it's broken down على طول. It's only secreted when it's needed, and then it's removed. But C-peptide stays, and that's why it's a measure of how much insulin is being produced in the body. Okay. Now, for both of those, the treatment is usually just resecting the part of the pancreas or the tumor. Because there's nothing much you can do about it. If it's something secreting from the inside, you need to remove it. A 39-year-old man with untreated diabetes type 1 is brought to the emergency room. An injection of insulin would be expected to cause an increase in his
C.
You have a C? Any other answers?
No, I think it should be D. Becomes metabolic alkalosis, I think.
Now we have a D. Okay, another D. Yes, good job. The answer is D. Why? Why C is wrong, first of all, Yasser, is because we said one of the functions of insulin is cellular uptake of potassium. So it won't
Yeah,
cause
so
any.
it would decrease blood potassium concentration.
Good job. And like, what do we see in type 1 diabetes? What thing do we see in type 1 diabetes that we can say, خلاص, this is type 1 for sure and not type 2? What's the differentiating feature of type 1 diabetes? It's ketoacidosis, okay? So keto acids in the blood. And ketoacidosis in type 1 diabetes will cause the blood pH to be low, صح? So once we give an insulin injection, it will increase the blood pH back to normal because we have low blood pH in type 1 diabetic patients caused by ketoacidosis. We'll discuss more in a bit. Let's discuss this question as well. A patient of type 1 diabetes has developed polyuria and excessive thirst. Laboratory results show chloride, bicarbonate, and glucose. Which one of the following abnormalities do you expect in this patient? All we need from the question is that he has type 1 diabetes. We have a C. Any other answers? Well, should we move on? طيب عبد الرحمن. Okay, we have a complete guess. That's an A. طيب عبد الرحمن, would you explain why it's C? Although we said no, the answer is C. Good job, by the way. MashaAllah. I didn't expect any of you to get the صراحة. So we just said insulin decreases the potassium because it increases cellular uptake, صح? I mean,
صح.
أيوة.
Yeah.
So yeah, so why do we have decreased total body potassium? Because in diabetes type 1 we have no insulin, صح?
Yeah, we don't have
Why do we
insulin. Oh, I'm going to be honest, this was an educated guess. But my reasoning was if I don't have insulin for the cells to take up the potassium, there's going to be a lot of insulin in the serum. The body is going to get rid of that. It's going to get filtered out. That was my thinking.
MashaAllah. It's a guess, but it's completely correct. Notice here we said total body, but every time we spoke about potassium before, we said blood potassium. So total body potassium is different from blood potassium. Now, because we said that insulin increases the potassium cellular uptake, the total potassium in the body inside the cells will be higher than normal because potassium is being stored in the body. The blood potassium, however, is going to be low. So we'll have hypokalemia, which emia means blood. So it's specifically talking about the blood. Okay. We'll have hypokalemia, but the total body potassium won't be lower than normal. However, in diabetes type 1 patients, type 1 specifically, only type 1, not type 2. In type 1 patients, since we don't have insulin, the cells can't uptake potassium. So it's all gonna stay in the blood. And since it's in the blood, and aslan, what's another differentiating feature of diabetes in general is polyuria. Okay, they urinate a lot because of the high glucose level in the blood. صح? The glucose is highly osmolar, so it pulls a lot of water, and that's why they urinate a lot. With this urine, they're losing a lot of potassium since potassium is in the urine, and therefore they'll have lower total body potassium. This is a very important differentiating point. So do you guys understand why it's C now? Here, okay. Now, this is a very important table. For Dr. Yaqeen lecture in general, look at the first 8 tables. They're very important. All of his questions are going to be from the first 8 tables, okay? So, the differentiating feature between type 1 and type 2 diabetes is for type 2, we have high insulin. For type 1, we have low insulin. Or no insulin, حتى, not just low insulin, we have no insulin, okay? This is the most basic and most important difference between type 2 and type 1 diabetes. Okay, in both type 1 and type 2 diabetes, we'll have high blood glucose, but the reasons are different. For type 1 diabetes, we have high blood glucose because simply we don't have insulin. For type 2 diabetes, we do have a lot of insulin, excess insulin, and that's what caused insulin resistance, and that's what causes insulin resistance, and that's why we have high blood glucose. Okay, now that's why in type 1 diabetes we need insulin for treatment. You can't survive without insulin if you're type 1 diabetic. Type 2, you already have a lot of insulin, so most probably you won't need extra insulin. خلاص. Okay. Now sometimes they do give insulin. Why? Because the cells are desensitized, but if you give a higher dose of insulin, they respond more, obviously, because there's just even higher levels of insulin. Now, but this is not advised because insulin has other effects other than glucose. So it's advised to control your lifestyle instead. Just control your diet and control and exercise and stuff like this. Okay, so break your own glucose basically. For age, we said type 1 diabetes happens in kids mostly and young adults, But in type 2, it's always in patients who are older than 40 years old. ليش? Because as we said, insulin resistance happens in a very long time. And it has to be chronic and it has to happen for years in order for you to get type 2 diabetes. Type 2 diabetic patients are always or mostly always obese because that's one of the things that cause insulin resistance. Genetic disposition plays a big role in type 2 diabetes, bigger than type 1 diabetes. And the type 1 in type 1 diabetes, you'll have autoimmune cells. That's the meaning of this. Okay. Now you'll have an autoimmune cells. They're attacking your self. These are the self antigens. So in type 1 diabetes, you'll have autoimmune destruction of the B cells. That's why you don't have insulin. Glucose intolerance means if you give them glucose, will they be able to tolerate it or not? It's severe in type 1 diabetes. You can't give them glucose because they have no insulin. So in type 2 diabetes, they do have insulin, but they're just desensitized to it. Now, I'll skip those. Ketoacidosis is very important. It always happens in type 1 diabetes only, and it's very rare in type 2 diabetes. If you see a patient with ketoacidosis, that's type 1 على طول. Why? Because since there's no insulin, the body will take the fatty acids into another pathway, the fatty acids and the glucose and everything, it will take it into another pathway called the ketone pathway, and you'll take this in mole, or you took this in mole, and that will increase the ketone production. And ketone is obviously an alcohol. So one of the presentation of type 1 diabetic patients is alcohol smelling breath because of the ketones. And that's rare in a type 2 diabetes because we do have insulin. Insulin is not absent. So in type 1 diabetes, since absent ketoacidosis is very common, and this is the most thing that we're afraid of from happening, اللي هو DKA or diabetic ketoacidosis, because it's fatal. And this is not important. Okay, one last question. 78-year-old patient present to the ER for a seizure. He is lethargic and complained of constant thirst and polyuria. His labs showed normal blood pH. Which of the following is the name of this condition? Did you guys see the answer or la? You have a D.
D.
You have a D. ياسر D ولا B?
D.
D. Good job. It is D. Hyperosmolar hyperglycemic state, or HHS for short. Now, these are also important. These are basically manifestations of type 1 and type 2 diabetes. I like to think of them like that instead of thinking of them as separate symptoms. Just think of them as manifestations of type 1 and type 2 diabetes. For type 1, if it persists and it's uncontrolled and you don't take insulin, you're going to get diabetic ketoacidosis. And for type 2, if it's uncontrolled, then you'll have HHS, or hyperosmolar hyperglycemic state. What's the difference? For diabetic ketoacidosis, obviously we already mentioned the reason, and no, it's high levels of ketones in the blood, which will cause acidosis. For HHS, it's excessive osmotic diuresis, which means there's too much glucose in the blood, and that will cause a lot of water to be pulled out. And classic presentation is polyuria, thirst, polyuria because there's too much glucose and it's pulling a lot of it's pulling a lot of water outside, and thirst because a lot of water is being pulled outside. And both are fatal. Yani both are severe diabetes. Okay, and both are fatal and both need to be controlled quickly. And the treatment for both is IV fluids. I'll totally give fluids because of the hyperosmolar state they're in. For ketoacidosis, it's because of ketones. For hyperosmolar hyperglycemic state, it's because of glucose. You give insulin immediately and IV, and you give you don't give it as an injection. You give it as IV, okay? Because خلاص, you need to act right now and quickly. And you also give potassium because in both cases, you're losing a lot of potassium, okay? Now, it's very important to know the difference in presentations. For HHS, you'll have thirst, polyuria, and lethargy. Those, as soon as you see those, خلاص, that's HHS. And something that might help and that might give you in the question is that the patient is type 2 diabetic and an elderly patient, okay? So if you see any of these 5 things, that's probably HHS. For diabetic ketoacidosis, you'll have delirium, abdominal pain, and dehydration. Now, this, they'll probably tell you that the patient is type 1 diabetic. They'll tell you fruity breath, which is because of the alcohol smell, or the exhaled acetone, which is one of the ketones. And for both, you'll have polyuria, okay? That's it. Does anyone have any questions? Okay, thank you guys so much for attending. I hope you benefited. Please scan this QR code. Yeah, I think we should be done.